Tetralogy of Fallot is the most common type of cyanotic heart disease, which is classically understood to involve 4 anatomical defects. Narrowing or stenosis of the right ventricular outflow tract, a wide subaortic ventricular septal defect, a shift of the aorta towards the right side, overriding aorta, a right ventricular hypertrophy, a consequence of the infundibular stenosis. Through the ventricular septal defect, blood flows from right towards left because of an increase in blood pressure in the right ventricle due to the outflow tract stenosis. Consequently, oxygen-poor blood mixes with oxygen-rich blood, and that causes the cyanosis. Clinical aspects of the Tetralogy of Fallot depend on the degree of the right ventricular outflow tract stenosis. Usually, primary symptoms are cyanosis, anoxic spells, fatigue, a systolic murmur, 3 or 4/6 in the mesocardium with single-second heart sound. Cyanosis characterizes the Tetralogy of Fallot, and it depends on the degree of the right ventricular outflow tract obstruction. Children with mild infundibular stenosis may not present cyanosis. These cases are referred to as pink Tetralogy of Fallot. Anoxic spells occur with severe infundibular stenosis and cause a sudden and marked increase in cyanosis, followed by pallor and possible lipothymic. Fatigue occurs with severe infundibular stenosis. Children get tired easily and they often squat. They adopt a knee-chest posture. Retarded growth may occur as well. The most useful methods of diagnosis are electrocardiography, ECG, chest radiography, echocardiography, cardiac catheterization. Electrocardiography shows right axis deviation and right ventricular hypertrophy. Chest radiography may be useful for the diagnosis as it shows a typical view of the Fallot. Pulmonary hyperperfusion and left cardiac border uplifted apex, which is referred to as boot-shaped heart. Echocardiography allows now the diagnosis of Tetralogy of Fallot in more than 90% of cases, without cardiac catheterization, angiography, or other techniques. Parasternal short-axis view of a case of Tetralogy of Fallot. The infundibular septum is deviated antero-superiorly and causes pulmonary infundibular obstruction, as shown by color flow mapping. Subcostal oblique anterior projection showing a case of Tetralogy of Fallot. The antero-superior deviation of the infundibular septum is clearly seen, causing subvalvar pulmonary stenosis. This view also shows hyperplasia of the pulmonary trunk, while the pulmonary branches appear of adequate size. Although cardiac catheterization is less required, the hemodynamic analysis may be useful to evaluate the following structures: anatomy of the pulmonary arteries with agenesis or hyperplasia, presence of coronary anomalies, presence of multiple ventricular septal defects, anatomy of the aortopulmonary collateral arteries. Surgery is the sole definitive treatment for Tetralogy of Fallot. Medical therapy with beta blockers may be useful during the first months of life in order to prevent anoxic spells for patients who are waiting for surgery. Surgery is the sole definitive treatment for Tetralogy of Fallot. There are 2 types of surgical treatment: palliative surgery and corrective surgery. Palliative surgery is usually carried out in infants 2 or 3 months of age who develop anoxic spells. Palliative surgery consists in the construction of a shunt, a connection between the aorta and the pulmonary artery, in order to increase blood flow into the lungs. Corrective surgery is the sole definitive treatment for this disease. It is carried out under extracorporeal circulation and it follows three main steps: resection of the infundibular hypertrophy, closure of the ventricular septal defect, reconstruction of the pulmonary artery. There are many different surgical approaches. The transventricular approach involves a longitudinal incision of the right infundibulum followed by the resection of the hypertrophic septal band of the parietal band and of the supraventricular crest. Here is a right ventricle inside view that shows the procedure. Once the right ventricular outflow tract stenosis has been relieved, ventricular septal defect is repaired with a pericardial or other patch. In the end, the right ventricular outflow tract is reconstructed using a pericardial or other patch. With hyperplasia of the pulmonary artery ring and trunk, the pulmonary artery needs to be enlarged through a transannular incision, even removing the valve. This procedure involves the resection of the hypertrophic septal band. Of the parietal band and of the supraventricular crest. Once the right ventricular outflow tract stenosis has been relieved, ventricular septal defect is repaired with a pericardial or other patch. As the animation shows, a dysplasic pulmonary valve should be removed. In the end, the right ventricular outflow tract and the pulmonary artery are reconstructed using a pericardial or other patch. With severe hyperplasia of the pulmonary trunk, a valve conduit should be used. In the animation, the valve conduit is placed between the right ventricle and the pulmonary artery bifurcation. Through the valved conduit, blood flows directly from the right ventricle into the pulmonary artery.